Good evening. This is Carol Allingham, and tonight I have the pleasure of talking to you about 3 topics that every medical assistant should be familiar with. One of them being out-of-hospital do not resuscitate orders. Secondly, we have handicapped parking in Pennsylvania. And third, drug enforcement and drug abuse in the medical profession. You should have a few handouts in front of you. One of them, in terms of the out-of-hospital DNR orders, our first topic will be a packet from the Department of Health, Pennsylvania Department of Health, and it has a picture of a DNR bracelet, a DNR card, and a nice DNR image there. You should also have a handout of part of a man's chest with an odd-looking tattoo. Why is she giving us pictures of tattoo, you probably wonder? Well, we will get to that in not too much time. In terms of handicapped parking in Pennsylvania, I don't have any handouts for you. The information I have is taken right off the website for PennDOT, the Pennsylvania Department of Transportation, and if you need a printout, you can find it there. And finally, for drug enforcement and drug abuse in the medical profession, there is a nice little pamphlet from the United States Drug Enforcement Agency, the DEA. It's right off their website, and it is very possible that you will have copies of that for tonight. If not, don't fret. You can go to the website and download it yourself if you wish to. But it's good to know that it's there. Okay, first topic is out-of-hospital do not resuscitate orders in Pennsylvania. We don't know where life is going to take us, do we? It is very possible that you could be working in the office of an oncologist who specializes in the treatment of cancer, an internist who specializes in treating people with multiple diagnoses and or advanced age. Unfortunately, multiple diagnoses and advanced stage tends to go together, so the internist takes care of more complicated patients. Or even in a general practitioner's office, you could very well be dealing with someone who has a terminal illness. And yes, I know what you're thinking. Carol, we talked about that enough when we did advanced directives and all that stuff. I totally agree. We are only here to talk about how to get the order and in what situations it is appropriate. I think this is very useful knowledge for you because it is very possible that you will be helping people to get these orders and processing the paperwork and so forth. So we are going to take this from a strictly clinical point of view. Well, first I had to drop my papers. Okay, here we go. So I'm just going to march right through the major points of the handout that I gave you. I just would like you to be familiar with this information. So this all started with the Out-of-Hospital Non-Resuscitation Act, and it was put into effect in January 28th of 2007 in Pennsylvania. This act empowers a person with an end-stage medical condition or an appropriate representative of that person to secure an out-of-hospital do not resuscitate or DNR order, and at the person's option or the option of the authorized representative, an out-of-hospital DNR bracelet or necklace. Now, there was a law before this, which was called the DNR Act, and just as those were issued under that previous act, these items are available. And those are the things that are pictured on the front of your packet. And this act also specifies the circumstances under which an appropriate representative of a person who issued a living will under the Living Will Act, you know about living wills, don't you, can access do not resuscitation services as well. So what in the world is an out-of-hospital do not resuscitation order? If you've ever worked in any kind of clinical setting, a hospital, a nursing home, people have, often they'll be indicated with a red bracelet that is, a person has a DNR, do not resuscitate order. So while that person is an inpatient in that facility, they have a physician's order documented on their chart that should respiratory or cardiac arrest occur, they are not to be resuscitated. However, what happens when these people go home from the hospital and their intent is the same? They do not wish to be resuscitated, and that's fine. They can execute a living will, durable power of attorney, things like that. But think about what happens when somebody codes in the community. The first person, somebody calls the hospital, somebody calls 911, and the ambulance comes, and the person may not be home. They may not have a copy of their living will folded up in their wallet while they're at the shopping mall where they happen to have their arrest. Those documents may not be available. So if they are wearing a bracelet or a necklace that specifies do not resuscitate, and it is consistent with the procedures prescribed by state law, then the people, the paramedics and the EMTs in the ambulance will not begin CPR. And bystanders who are well educated will not either. And that would be consistent with the person's choice. Anyway, so what is it? It's a written order that is issued by a person's attending physician that directs emergency medical system providers or emergency medical services providers. What are those? Those are the people who come in the ambulance. To withhold CPR from the person in the event of the person's cardiac or respiratory arrest. Thus, if an ambulance is called to attend a person for whom an out-of-hospital DNR order has been issued, and the ambulance crew observes the out-of-hospital DNR order with the original signatures with the person, or observes that the person is wearing an out-of-hospital DNR bracelet or necklace, then the ambulance crew will not attempt CPR unless it is appropriately communicated to a member of the crew that the out-of-hospital DNR order has been revoked. Okay, that's what it is. It's like your living will for the community. You don't want CPR. A little bit of terminology here. What is the difference between cardiac arrest versus respiratory arrest? In this situation, it's a very simple idea. Cardiac or respiratory arrest is the process which occurs when a person's heart or breathing, or both heart and breathing, stop. That's basically it. So why would a person have a out-of-hospital DNR order? Let's look at some of the philosophy behind it. CPR, when it's successful, restores heartbeat and breathing and allows people to resume their previous lifestyle. The success of CPR depends on many factors: the overall medical condition and how quickly CPR is started after the arrest. Now, age alone does not determine whether CPR will be successful, although illnesses and frailties that go along with age often make CPR less successful. When a person has an end-stage medical condition or is in a terminal condition, CPR may not work, or it may only partially work, or it could leave the person brain damaged or otherwise in a worse medical state than the person was in before the arrest occurred. So to avoid this possibility, some people prefer to be cared for without aggressive efforts at resuscitation when they suffer a cardiac or respiratory arrest. Also, some people who have an end-stage medical condition or who are in a terminal condition perceive death by cardiac or respiratory arrest to be a natural conclusion to their life, and they don't want CPR to prolong their life. And for the same reason, some people may not want to receive CPR should they become unconscious without a known medical possibility of returning to consciousness. So remember our patient bill of rights, it's a decision, and every person makes a decision for him or herself. So remember the power of attorney, the healthcare surrogate, or other agents. Can somebody else request a DNR order for another person? Yes. If a person qualifies to request, if the patient qualifies to request the DNR order for himself or herself, then no other person can request it. That wouldn't make sense, would it? But if the person is unable to communicate and the advance directives come into play, then yes, a healthcare power of attorney or a surrogate may request a DNR order out of the hospital for a patient, so long as if the person requesting the order is 18 or older, or a high school graduate, or has been married or emancipated. Okay? What does the patient need to do to request an out-of-hospital DNR order for themselves? How can they be competent to do so? The same level of competency is required as for the level of competency for informed consent. If a person has an end-stage medical condition who is competent at 18 years of older, or if under 18 years has graduated high school, been married, or is emancipated, that person may request an out-of-hospital DNR order for him or herself. So, okay, we're throwing these terms around: end-stage medical condition or terminal condition, and it's likely that you've come across people with these kind of labels on them. Let's be very specific about what that means. An end-stage medical condition or a terminal condition is a situation where the condition is incurable and it is irreversible, and the disease process is somewhat advanced in the person, and the attending physician believes that the condition is going to result in the individual's death, and that death is likely to result despite additional medical treatment. That's the situation we're talking about here. So where does one go to get an out-of-hospital DNR order? Right to the attending physician. Now, we have people, like I mentioned before, with multiple different conditions. They may see an oncologist, they may be seeing an endocrinologist for hormonal issues, they may be seeing an orthopedic doctor for musculoskeletal issues. They may have different attending physicians. So it's up to the physician. If the patient asks for a DNR order and is competent and has the appropriate diagnoses and prognosis to qualify, it is up to the physician and attending physician of that patient to make that determination whether to issue the order. Okay, so now maybe you can guess why you have a picture of a man's chest with an odd tattoo on his chest. That picture that you have is actually from the chest of an emergency doctor who, at the time of the article where that picture came from, was retired. And having been an emergency room doctor, he had handled many, many cases over the years where people came in and they had arrested out in the community, and CPR was initiated, and it's often not successful. Let's be honest, when it's initiated in the community, because it takes a while for the ambulance to get there, and we know that brain damage begins within 2 to 3 minutes after the deprivation of oxygen begins. So there often is not a wonderful result when a person arrests in the community. So this physician, after he retired, decided to have this little tattoo put on his chest. And if you look at that picture, actually what it is a picture of, it's supposed to be defibrillator pads and an electrical coil, meaning do not. And it has the circle with the line through it, meaning he doesn't want to be resuscitated. That's what he wants, that he doesn't want defibrillation. Now, that didn't happen. He didn't get that in the state of Pennsylvania. It was somewhere in the Midwest, I think, that physician came from. But in Pennsylvania, if a person gets a tattoo of DNR, and we have a couple other examples up on the screen here, none of those are really probably going to work in Pennsylvania. The law provides that, and it is at the very end of this handout. And the question is, what if a person wears a bracelet or a necklace, it doesn't even mention tattoos, that is not approved by the Department of Health? EMS providers are not authorized to comply with an out-of-hospital DNR order, bracelet, or necklace that has not been approved by the department. So, even if they come from another state and they have a different kind of DNR bracelet or necklace than we have in Pennsylvania, unless it's been approved by Pennsylvania, that is not likely to be honored in Pennsylvania. So it's good to be mindful of that. If you have somebody who comes to your practice and has one of these and just moved in from another state, or they have one of these tattoos, or they have some kind of alternative means of expressing their wishes, perhaps they should be advised that it's likely that they are going to receive CPR if they code here in Pennsylvania. So another question on the handout is, can this be revoked? Well, it's hard to revoke a tattoo, isn't it? No, I didn't mean that. I meant, can the legally prescribed out-of-hospital DNR order in Pennsylvania, can that be revoked? Absolutely. All the person has to do is tear up the document and remove the necklace and or bracelet and consider it to be revoked, and make sure that they notify their physician of this decision. Because in this day of EHRs and EMRs, we want all that information to be up to date and accurate. Another question was, what about if a woman is pregnant and she has one of these, she has the appropriate documentation and or bracelet or necklace? It is the same as it would be for a living will. In order for an attending physician to issue an out-of-hospital DNR order for a patient the physician knows or should know is pregnant, requirements need to be met that do not apply to the issuance of an out-of-hospital DNR order of a patient who is not known to be pregnant. An obstetrician must examine the patient, and both the attending physician and the obstetrician must certify on the patient's medical record that, to a reasonable degree of medical certainty, the provision of life-sustaining treatments will have one of the following consequences. 1, it will not maintain the pregnant woman in such a way as to permit the continuing development and live birth of the unborn child. Or 2, it will be physically harmful to the pregnant woman. Or 3, it will cause pain to the pregnant woman which cannot be alleviated by medication. The patient's attending physician is not required to perform a pregnancy test unless the physician has a reason to believe that the woman may be pregnant. Okay, so let's say she's got the order and something happens and she arrests and the EMS people show up. May an EMS provider comply with an out-of-hospital DNR order for a pregnant patient? yes, they may comply, but if an EMS provider knows that the patient is pregnant, the EMS provider may not comply with an out-of-hospital DNR order unless the EMS provider confirms that the attending physician and an obstetrician have certified on the patient's medical record that, to a reasonable degree of medical certainty, it is exactly the same issue, the same criteria that we see in the issuance of the DNR order. So, so the bottom line is, if the emergency medical person knows or has reason to know that the lady is pregnant, he has to go ahead and provide CPR. And there are lots of other questions and answers on this brochure. I just covered the major points, but I would just like you to be aware, if a physician wants to order one of these for a patient, they come from the Department of State Department of Health. Alrighty then. Moving on. See, we're really moving fast here tonight. We are now talking about the handicap parking guidelines in Pennsylvania. And this is just a very brief summary. I think this is important. There may be situations where you could recommend this for a patient. When you know the conditions required and they're really kind of a simple list, you may be able to recommend this and be really helpful in a patient's life. Not only that, but also impress your employer. And we always want to do that, don't we? Okay. All this information is directly from the Pennsylvania Department of Transportation, or lovingly known as PennDOT website. And this information was accurate as of December of 2013. So first thing to know, if you want to apply for a placard, that's the thing that you hang on your rearview mirror, there is no fee required. There are two different forms to be completed in order to obtain a person with disability or a severely disabled veteran placard or a severely disabled veteran motorcycle decal. And you do need to take any of these to a notary public. And the good thing is that there's usually a notary public in doctor's offices nowadays. In fact, you may be sent training. I think it's like a 1 or 2 day training course to become a notary public when you get to work in an office. And on the website they have links to the various applications, and then they have information as to what the criteria are, for the different kinds of placards, and it's very clearly spelled out. And then you have, of course, the address as to where it gets sent to PennDOT. So here are the eligible conditions to get a handicap parking placard or a license plate. So it has to be certified by a healthcare provider, a doctor, a nurse practitioner, a physician's assistant, and they just sign a certain place on the application, and that is the degree of certification that's required. So if the person is blind, does not have full use of an arm or both arms, cannot walk 200 feet without stopping to rest, or cannot walk without use of or assistance from a brace, a cane, a crutch, another person, some kind of prosthetic device, a wheelchair, or other assistive device, or is restricted by lung disease to such an extent the person forced expiratory volume for 1 second when measured in spirometry is less than 1 liter, or the arterial oxygen tension is less than 60 milligrams of mercury on room air at rest. Gee, pretty specific, huh? Well, that is the kind of information that you would get if you were going to a pulmonologist or had some respiratory function studies done. Once again, if a person uses portable oxygen, then they are eligible. If a person has a cardiac condition to the extent that the person's functional limitations are classified in severity as class 3 or 4 according to the standards set by the American Heart Association. If the person is severely limited in his or her ability to walk due to an arthritic, neurological, or orthopedic condition, and that's a nice and loosely phrased, or if a person is in loco parentis of a person specified in one of the above mentioned disabilities. So what is in loco parentis? That is a Latin-based legal term, which means that the person is acting as a parent would on behalf of a minor or a disabled person. Okay, so is the person taking care of somebody who has any of the above conditions 1 through 8 would be eligible to have handicap parking stickers. Placards or plates. And they also give you a card to put in your wallet. So, good for you to be familiar with those conditions. As far as applying for the handicapped status from PennDOT, once again, the application form is available on the PennDOT website. You have to print it out and fill it out. You pick a code number 1 through 8 to indicate which condition you have. Take it to your doctor signs it, and you mail it in. And all your stuff arrives in a few weeks' time. So that's that. Some more handy knowledge to have for medical assistance is the drug enforcement and drug abuse in healthcare. This is a very big issue. I think we've talked about how stressful healthcare can be. You'll find out people often work with a lack of sleep, and they're performing duties that require a lot of concentration, a lot of precision, and a lot of stress, a lot of accountability. And then there's a lot of drugs around. So it's kind of a situation that is full of potential problems for people who are vulnerable. And we all have vulnerable times in our lives for various things. So remember all that work, all the studying we did about addiction in the beginning of this class? Well, this is another reason for it. It seems to be permeating our world. We're becoming more aware of it. People are more in the open about it. So just be aware that this is an issue in the healthcare workplace just as much as in any other workplace. Okay, so how do we get about doctors having DEA numbers? So doctors, when they become doctors, they apply to the Drug Enforcement Agency of the United States, the federal DEA, and they receive a number. It has 9 characters. It's a mixture of letters and numbers, and there is a formula to those letters and numbers that they can tell if it's a fake number or a real number if somebody tries to be fraudulent. It enables that doctor to prescribe controlled substances. So if a doctor prescribes a controlled substance, they will have to write their DEA number on the prescription pad. Now prescription pads are becoming a thing of the past, so the DEA number, if they're calling in the prescription, they would give that number over the phone. But now we are having less and less phone orders of controlled substances being acceptable. So the DEA number is somehow submitted along with the prescription for the controlled substance, so that they can identify that the person who is prescribing it is indeed the doctor to whom the number was assigned. So, what is a controlled substance exactly? Well, there are lists of them in the law. It is a drug that has been declared by federal or state law. It's actually federal and state law to be illegal for sale or use. except when it is dispensed under a physician's prescription. The basis for control and regulation is the danger of addiction, abuse, physical and mental harm, including death, the trafficking by illegal means, and the dangers from actions of those who have used the substances. So they're drugs that are dangerous for any number of reasons. Many, but not all, controlled substances are narcotics. And we're going to take a peek at the relevant state law. And this is actually just the first paragraph of the Pennsylvania law regarding schedules of controlled substances. Okay, so it's the section lists all controlled substances. So if you look, let's see, under the word general, the sections and the page numbers, the section numbers, this, if you would go to the law library, go to the law book, so you can look it up online, you would find pages and pages of listing of all controlled substances in the state of Pennsylvania and the class which they are regarded as. And they are classed according to their addictive ability. I wasn't going to put all these pages on a slide. And besides that, they are chemical names. They aren't. They don't list them as the brand names. So it's just a lot of big chemical words in the law. So, but they are very clearly delineated which drugs have to be controlled to which degree. And this is very clearly spelled out in state law and federal law as well. So what does this all mean to you working in the medical office? I want you to understand that your employer will have very clear policies and procedures defining how to handle, how these substances should be stored, and who may and may not administer them in the medical setting. And what you will want to do is know these policies and follow them precisely. It is very possible that you may have nothing to do with that part of the practice when you work there. But if you work in a pain clinic where they do a lot of injections, or you work in any kind of medical setting where they do a lot of local anesthetics and they do sedation and local anesthetic with their procedures, those substances are going to be around. And the people who have to handle them they have to know their job in handling them. If you are to be involved in the handling or use of them, then you need to be very well educated as to what is required of you to be compliant with your employer's policy. One thing I will say, never ever sign a drug inventory sheet based on trust. In other words, somebody comes up and says, look, so-and-so went home. I need another person to verify that there are so many pills in this bottle, or there are so many cc's in this bottle or syringe. Could you just sign this for me? You need to actually look at, and probably it's going to be in a blister pack. They really don't put pills in bottles anymore. But in the old days, we actually had to take the pills out of the bottle, put them on a pill counter, which is just a plate with a little divot in it. And you took a knife and you just scraped them across and put them in the little divot and then rolled them back into the bottle. But nowadays, things are in blister packs. So you just look at, you have to look and make sure that the amount on the sheet is the amount that's there. And if it's not the same number, don't sign it. Okay? I will tell you a story in a few minutes as to why this is the smart thing to do. And as far as verifying a waste, what happens is a lot of these medications come in syringes and they're prepackaged by the manufacturer. So you'll have a syringe and it's got so many cc's of morphine in it. Well, let's say the patient only required half of that syringe. Well, you're not allowed to take the remainder of what that patient didn't use and use it on another patient, because the patient gets billed for the full syringe. So you can't double bill for the same syringe. So what you have to do is whatever is unused in that unit dose package, it has to be wasted. So what they do is just squirt it into a trash can or a sharps container, and they have to have a person witness they're doing that. And that's called a waste. And then that gets documented in the narcotics log. But if a person comes and says to you, look, I had to waste 2 cc's of morphine, could you sign, or no, 0.2 of a cc of morphine or whatever, could you sign this to confirm that I wasted it? But you didn't see them waste that, don't sign it. If you have to, if you are asked to participate in documenting the handling of controlled substances, you have to be very astute and make sure that you witness exactly what was done with them and or how many are there. The DEA does send agents into doctors' offices to do inspections on their records and their procedures and how controlled substances are handled. I know somebody who works in a pain clinic, and she literally had somebody some tall guy in a black suit walk up to the front desk and flash his pretty gold badge from the DEA and inform her that he was there to do an inspection. And so she did what any smart medical assistant does. She called the supervisor to handle it. So that's something somebody in management needs to take care of. But it does happen, so don't be too shocked if it happens when you're at the front desk somewhere. Okay, I want you to be very much aware that a licensed healthcare professional, and by that I mean a physician, a nurse practitioner, a nurse, a physician's assistant, who mishandles or misuses controlled substances is subject to disciplinary action by the board who licensed them. In Pennsylvania, that would be the State Board of Nursing for nurses and the Department of State for physicians. They can have their license suspended or revoked, or any other kind of disciplinary things happen. And that is a matter of public record. Okay, so that gets on the website. And here are some examples I pulled off the website of the Pennsylvania Department of State, and they're from various months in this year, and these are all in Pennsylvania. So let's just go down a couple, and these are just random examples. I don't know these people. I have no vendetta against them, but like I said, it is a matter of public record, and I do want you to see that these things actually do happen. So here we have, back from May 14th of 2013, we had a doctor in Jenkintown, Montgomery County, was suspended for at least 10 years based on his conviction of multiple felony and misdemeanor violations of the Drug Act. Okay, next we have a physician from Lewisburg, Union County, was indefinitely suspended for no less than 3 years, such suspension to be immediately stayed in favor of no less than 3 years probation. So he's on probation because he failed to comply with the standards and procedures set forth therein for prescription of controlled substances. That was on June 25th. Montgomery County here again, this is May 28th of 2013. We have a physician from Melrose Park, Montgomery County, was ordered to voluntarily surrender his license while his criminal case is pending because he was guilty of immoral or unprofessional conduct by dispensing controlled substances to drug-dependent persons. So doctors need to be very careful of to whom they are prescribing these meds, because patients can get doctors into trouble. Remember in the beginning of the class we talked about why a physician may want to terminate a therapeutic relationship with a patient? Well, this is one of them. If a patient is drug dependent and is drug seeking with that physician and the physician catches on, the physician doesn't want to lose his or her license, so they need to terminate those relationships with patients. Okay, so here is another doctor in Wynwood, Montgomery County on May 6th of 2013. He was automatically suspended for having been found guilty of ungraded felonies in violation of the Drug Act. Once again, here's one from Elkins Park, Montgomery County, automatically suspended based on his felony conviction under the Drug Act, and that was on May 28th of 2013. And finally, we have a doctor in Moncton, Maryland, and he had his license indefinitely suspended for no less than 3 years, immediately stayed in favor of no less than 3 years of probation, retroactively applied to September 11th of 2012 because he is unable to practice the profession with reasonable skill and safety to patients by reason of his illness, addiction to drugs or alcohol, or mental incompetence. And these are just some of the physician things I said, like if you go to the Pennsylvania Department of State website, if you go under the licensing, Professional Licensing Bureau, they have a list of every kind of license that is provided by this arm of the government. And you can look up nurses, funeral directors, nursing home administrators, physicians, physical therapists, any of those people, and they will have disciplinary actions when the licenses of those people were affected because of things they did. And they're not all, I just pulled out some drug-related suspensions and disciplinary actions, but there are all kinds of different actions, disciplinary actions that can be taken. But I just want you to be very much aware that this can happen. This can happen to a doctor you know. Hopefully it will never happen to a doctor that you work for, but I want you to be smart. I do want you to be aware what to look for as far as how to recognize if a coworker could be abusing or addicted to drugs. So hopefully you have the brochure that I found on the website. If you don't, it's okay. It's located on the DEA website, and I'm going to read you the most important points from the brochure. I just want you to be aware, and you need to do this in any profession, but in the medical profession, there are drugs around and lots of stress, and that's not a very good combination. So I want you to be able to recognize if you could have a coworker who has a drug issue. The person could have lots of absenteeism, and lots of times it's a no call, no show. They just don't show up for work here and there, or they're really late and there's no explanation. That's a person who's not taking care of themselves, and it could be due to some kind of substance issue. Really, you look for a pattern. You know, once in a while, maybe that sort of thing could happen, but look for a pattern. It could be difficult to find a person. A person goes to the bathroom a lot or goes outside a lot, just kind of isn't where they should be more of the time than usual. Or if there are drugs kept or stored there where you work and somebody's kind of always seems to be in that hallway or back around there, that's a red flag. Or somebody's just not reliable. They're not following through. They're not doing the things they should do, and they're getting sloppy. If there are multiple mistakes, inconsistent performance, mental changes like confusion, memory loss, difficulty concentrating, or it takes them a long time to do something simple. I hate to say it, but this sounds like me, and I don't have this particular kind of issue, but what you want to look for is not just one of these things, but if you start to notice one or two of these things or more, and the person seems to be really kind of losing their grip. And what a person will do is they will never admit that they made a mistake or did something wrong or weren't functioning as they should be. They just, that's kind of a part of the addictive mindset. The work could be sloppy. The handwriting could be changing and getting sloppier. Their personal appearance could be getting sloppier, and there may be hygiene issues with them as well. The person may be spending more and more time alone. And this is another one, wearing long sleeves when inappropriate. Some of us don't like air conditioning, so I wear long sleeves all the time. But I don't have this kind of issue, like I said. So be careful, when you make allegations, you ought to be reasonably sure that something's really wrong. But that's kind of what you look for in a person who's got an issue with a substance. So what do? This is not something you can handle on your own. I don't think you want to confront the person yourself. You want to take it to a higher level. The supervisor is a person who can keep an eye out and kind of watch for things. If you're noticing things, you're working next to the person, then the supervisor should be made aware so he or she can keep an eye out and watch the person. Sometimes the people who have these issues have a very long history of having these issues. So the supervisor may know that already know that the person has an issue, but you don't know that because you're not the supervisor and you don't have their employment record, and you don't need to know that. But if you notice something, the supervisor may already be on top of it, and or be aware the person has a history and that they need to be watched a little more closely or helped. Now, if your supervisor is the person who's having a lot of these behaviors, then you do want to go to his or her supervisor, because lots of times people are in recovery, then they're not in recovery all of a sudden, and then they need help to get back in recovery again. So that's pretty much what we have to say about that. Okay, so I'm going to tell you a few of my war stories with drug abuse in the healthcare workplace. I graduated nursing school. I don't want to say the year. Let's say it was a long time ago. Well, one of my very first jobs out of nursing school was at a nursing home. And what we did at the nursing home, I hate to talk about this because it just makes me sound so old, but the pills used to come in bottles, okay? And yes, we had a lot of patients and they had a lot of narcotics. So it was a nursing home. People have cancer and all kinds of things, and they have pain. So there were a lot of pain pills around. So I worked 3 to 11, and the way that the medications were handled in that day, the controlled substances, was when you came on duty, you counted every controlled substance that was in the drug room there, and they were actually in the bottles. So like I said, you had to pour the pills out and use a knife and count them. So I was, coming on duty, and a nurse was going off duty, and she picked up a bottle with 50 pills, and they were Demerol tablets, and she just shook them and said, "There's 50 in here." And then she went to put it in the cupboard. And I said, wow. And remember, I was new out of nursing school, but in this particular practice, I never changed for my whole practice. I always counted the pills. I didn't care what kind of a pain in the butt it was. I did it. And in this situation, it's a good thing I did, because I said, no, I got to count those. And she was clearly very annoyed at me. And she said, well, some people, some of us just trust each other. I said, well, I understand that, but I really do have to count them. So I dumped them out and I counted them out. And she was peeved at me, and I knew it, but I also knew that I had to do what I had to do. Well, about a couple months after that, that nurse was no longer around. And I had been told that she was actually stealing meds. She was stealing pills. She's the very same nurse that wanted me to just trust her, that let's just agree that there's 50 pills in here and not count them. So she was actually taking meds from the facility, and the way they found her was that she did not show up to work one day. Now, they knew that there were meds missing. And I don't know how she did this, except maybe other nurses didn't actually count. You know what I mean? Because you count coming on duty and you count going off duty. But if people didn't feel like counting or going through the motions, they just signed the sheet and said, yeah, there's 50 pills in there. And who knows how often it was counted. Now, the times I counted it, it was always accurate. So I don't know exactly how she did it. But she didn't show up to work for a few days. And the landlady went to check on her in her apartment, and they found her passed out in her apartment Apparently she'd been passed out for quite some time. She had been, some kind of overdose issue. She'd been vomiting all over the place and pretty sick. And they did actually find pill bottles from our work in her apartment there. And they were empty. So that's my first war story. That was my first job one of my first jobs out of nursing school, and my first encounter with on-the-job drug abuse. Okay, my second war story is about 10 years later, and I was working in an operating room, and what was I doing? I was circulating at that point. And we were called in over the weekend. We had an emergency orthopedic case, and I was a circulating nurse, and we were working with a nurse anesthetist, and there was an anesthesiologist who was in the building. And the nurse anesthetist needed to go to the bathroom. Well, when you're a nurse anesthetist and you're monitoring a patient's, making sure they're breathing and monitoring their constant drug infusions and their level of consciousness during surgery, you don't get up and go to the bathroom and leave them there. So the anesthetist paged the anesthesiologist so that the anesthetist could go to the bathroom. So the anesthesiologist came in, and I was very busy with my work. I wasn't paying attention with what was going on up at the head of the OR table. So the anesthesiologist finished the case. The nurse anesthetist never came back, and it was about 45 minutes that person was in the bathroom, on the alleged bathroom break. Well, the anesthesiologist finished the case. We took the patient to recovery room, and next thing you know, I didn't even hear this. When I was done with my job, I went home because we were just there on call. Well, next time I come back to work on Monday, I am told that the nurse anesthetist was found unconscious in the bathroom with the syringe stuck in his arm. He had been, during a case, using IV drugs in the bathroom of the hospital. And so that person, I never saw that person again in the professional context. So that's my second war story. My third and final war story with on-the-job substance abuse issues is another operating room case. That's one of the more stressful, in my opinion, one of the more stressful of medical settings. A scrub tech was setting up for a case. Person and I were not really good friends. To be honest, she didn't like me, and I wasn't too keen on her either. But you have that. You have personality differences, but you got to work with people, so you do. You be polite, and you do your job. Anyway, we weren't close. We weren't like the kind of friends that would talk to each other about personal issues. Anyway, we were setting up for our first case of the morning. She was scrubbed in. She had her sterile gown on and gloves and everything, and she was setting up the case, and she kept stopping and just looked sick. And as every minute went by, she looked sicker and sicker and more pale and more pale. And I said, I think you might need to go home. I think you really look terrible. And she'd stop and hold her stomach and then go back to working again. So I got really worried about her. So I went and got another nurse who got along well with her to come in the room and talk with her. I said, would you take a look at her, because I don't think she's well. And she had said to me at one point, I think I might be pregnant. And I said, well, okay, if you're pregnant, you got morning sickness, I get it. But break scrub and get somebody else in to set up your case and go to the bathroom, take care of yourself. But she wouldn't do that. And so the other nurse came in, and she saw how this girl looked, and we just couldn't get her to do something for herself. So we got another nurse in, and pretty soon there's three of us nurses standing there looking at this young lady who is just, I never saw a person green before, but she actually looked kind of sickish green. And make a long story short, she did end up going home, and she lived at home with her mother. And apparently her mother found her unconscious and had her called 911, had her brought back into the hospital. Apparently this person, she had attempted suicide the night before by taking an overdose of an over-the-counter drug. And the reason she took this overdose is because she did have a substance abuse issue plus an alcohol issue, and she wanted to end it, and that's what she did. But when she woke up in the morning and she hadn't ended it, she came to work. And so what happened was the medications that she took really did a lot of damage to her liver. She spent, I think, a few days in intensive care, and then she was taken to a facility to treat her addiction disorder. And then she did eventually come back to work after some treatment. But so those in 18 years of nursing as an RN are my war stories of encountering drug abuse in the workplace. And there are probably lots of other situations that I didn't catch. I really wasn't educated to look for those kinds of things like you are being educated. When I was trained, it wasn't something people talked about. So those are my war stories. And guess what? Can you believe it? We're done already. Oh my God, does the time go? So this being the end of this trifecta of medical assistant topics, I want to thank you and wish you a very good rest of your evening.